Hello everyone, welcome to our channel. In today's video, I will be discussing nephrotic syndrome, one of the important topics in pediatrics. At first, let's see definition of nephrotic syndrome. It is a clinical condition characterized by four key features, that is massive proteinuria with more than 40 milligram per meter square per hour or greater than 1 gram per meter square per day in children, and then hypoalbuminemia if serum albumin is less than 2.5 gram per deciliter, and third one is edema, and fourth one hyperlipidemia. And then classification. Here it is classified based on different criteria. At first, let's see based on steroid response. It is classified as steroid sensitive and steroid resistant nephrotic syndrome. And then based on histology, it is classified as minimal change disease and nephrotic syndrome with significant glomerular lesion, which includes focal segmental glomerulosclerosis, mesangial proliferative, C3 glomerulopathy, membranous nephropathy. And then etiology. Here the etiology is most commonly primary, that is idiopathic, and it might be secondary also in case of certain infection leads to nephrotic syndrome, and then drugs, malignancy, and even certain systemic diseases such as SLE, amyloidosis may lead to nephrotic syndrome. And if it is present before 3 months of age, it might be congenital or infantile etiology. Let's see pathophysiology. It is the increase in the permeability to plasma proteins, most commonly albumin, in glomerular capillary wall because of damage to podocyte or immune dysfunction. This causes massive protein loss in urine, which leads to hypoalbuminemia, and which causes decrease in the plasma oncotic pressure. Because of these, there will be resultant edema and lipoprotein synthesis, which leads to hyperlipidemia, which is one of the four features of nephrotic syndrome. And then clinical features. Here you can see periorbital edema. It is one of the earliest and most characteristic sign. And then generalized edema, including ascites, pleural effusion. These are due to decreased oncotic pressure, and throughout the urine because of proteinuria, oliguria because of hypoaluminemia, and then hypertension. Hypertension is more or less uncommon in minimal change disease, and it is present in significant glomerular lesions. And then complications. Here the infections are common, most commonly peritonitis, and most common organ is streptococcus pneumoniae. And then thromboembolism. How thromboembolism occurs? It's because loss of anticoagulants causing a hypercoagulable state and leads to thromboembolism. And then hypovolemia. The hypovolemia is due to shift of the fluid. And then acute kidney injury, hyperlipidemia, and hypocalcemia. It is due to loss of vitamin D binding proteins. And then the diagnosis. The diagnosis is by various investigation such as urine examination. It reveals proteinuria and lipiduria. And then serum albumin will be low because of proteinuria. And then serum cholesterol will be elevated. Blood urea and creatinine, it usually normal. And serum electrolytes. And then ASO titer anti-nuclear antibodies C3 levels are seen if secondary causes are suspected. And then the indication for renal biopsy, which includes age less than 1 year or more than 12 years. Then if it is gross hematuria is present and persistent hypertension, low complement 3 levels, and steroid resistant. And then management. The most important thing is management, and here we see the general measures such as salt restriction, diuretics for severe edema, ACE inhibitors, and angiotensin receptor blockers to reduce proteinuria, and management of hypertension, infection prophylaxis and treatment, vaccination. Vaccination, more or less, the immunization schedule is enough, and then high protein diet is advised. And then steroid sensitive nephrotic syndrome. Here, the most common drug is prednisolone, and then it is given as 60 milligram per meter square or 2 milligram per kg per day in a single morning dose for 6 weeks. And if remission occurs, it is given as 40 milligram per meter square or 1.5 milligram per kg on alternate days. You should remember, not daily, it is alternate days for 6 weeks. And in case of relapses, we follow prednisolone at 60 milligram per meter square daily until remission. So here no time limit is mentioned. In sensitive, we have mentioned for 6 weeks. Here until remission, no time limit mentioned. And then we can follow 40 milligram per meter square on alternate days for 4 weeks. And here we see infrequent relapses and frequent relapses. Frequent relapses is 3 or more relapse in year, and infrequent is 2 or less relapses in year. In infrequent relapses, we follow the same schedule. And for frequent relapses with alternate days prednisolone, we also follows alternate drugs such as levamisole, which is the first line drug, and then cyclophosphamide, mycophenolate mofetil, cyclosporin or tacrolimus or rituximab. And then the steroid resistant nephrotic syndrome. Here we see it is the failure to achieve remission after 6 weeks of daily prednisolone. So at first we start with prednisolone for every case, but after 6 weeks it may be classified as steroid resistance. And in case of steroid resistance, the renal biopsy is mandatory. And then the main drugs used are cyclosporin and tacrolimus. It is given as dose of 4 to 5 milligram per kg per day in 2 divided doses for the duration of 12 months, and then taper slowly. And tacrolimus, it is given as dose of 0.1 to 0.2 milligram per kg per day in 2 divided doses, and it is preferred over cyclosporin because of better lipid profile and less cosmetic side effects. And other alternative drugs are mycophenolate mofetil, cyclophosphamide, rituximab. And then a quick recap of the topic. It is characterized by proteinuria, hypoalbuminemia, edema, and hyperlipidemia. You should remember this classic tetrad because it is often asked in exams. And then the most common cause in children is minimal change disease, and the mainstay of treatment is steroids, that is prednisolone. And renal biopsy is reserved for atypical and resistant case, not for everyone. And if you found this video helpful, do like, share and subscribe, and drop your questions and topic requests on comment section. And thank you for watching.